It's 1:30. I'm going to welcome everyone to our final preventive medicine grand rounds. Today is June 5th, 2024. My name is Michael Cherry, and I'm the Residency Program Director for CDC's Preventive Medicine Residency Program. I have the pleasure today to be the moderator as we go over two of our residents' projects from the year while in the Preventive Medicine Residency Program. We'll be hearing from Lieutenant Commander Stephanie Ajuzie, who will be talking about the Public Health Accreditation process in the Department of Maryland, and Captain Jane Gwira Baumblatt, who will be talking about the National Health and Nutrition Examination Survey. And it's been my great pleasure to be able to have seen these two learn so much during the residency program at CDC, to grow, to work on their projects, and I'm glad that you're all going to be able to hear the work they've been able to do while in this residency program. Closed captioning is available, and the link is in the chat for closed captioning, and continuing education is available in CDC Train. You'll have to, the link will be in the chat, and you'll have to apply before July 8th, 2024 for the continuing education. There are no financial disclosures from our speakers today, and their views and opinions do not necessarily reflect the views of the Centers for Disease Control, HHS, the Maryland Department of Health, and we are just so glad and delighted to have the two of them here to speak to you today. So I'm going to turn the microphone over to Dr. Ajuzie, who will present first on the Public Health Accreditation process in the Department of Maryland. Stephanie?
Thank you very much. Good afternoon. It is with great pleasure that I have the opportunity to speak with you regarding my experiences working on the accreditation team at the Office of the Deputy Secretary for Public Health Services at the Maryland Department of Health. My presentation is titled The Journey to Public Health Accreditation. Our agenda will include introductions to the Maryland Department of Health, also known as MDH, and public health accreditation. I will then discuss some of our recent accreditation-related health planning and improvement initiatives, including the State Health Assessment and Improvement Plan, and the development of the revised MDH Public Health Services Strategic Plan. We'll then discuss the importance of performance management and plan alignment. Lastly, I will provide my lessons learned from this experience and my overall takeaways. MDH is located in Baltimore, Maryland, and is considered a super health department, comprising administrations for Medicaid, behavioral health, developmental disabilities, operations, and public health services. PHS is currently led by Deputy Secretary Dr. Kalyana Raman as one of 5 major units within MDH. MDH first achieved public health accreditation in 2017 and is currently under review for reaccreditation. Let's talk a little bit more in depth about what is public health accreditation. Public health accreditation is an opportunity for health departments to demonstrate a commitment to quality and performance while establishing accountability, transparency, credibility, and public trust. The Public Health Accreditation Board, also known as FAB, is a nonprofit that was developed to define, implement, and oversee the process of public health accreditation in the United States. The mission of FAB is to advance and transform public health practice by championing performance improvement, strong infrastructure, and innovation. Their emphasis is on both the foundational public health services and the 10 essential public health services. The foundational public health services, first developed in 2013 and revised in 2022, is divided into foundational areas and capabilities and rooted in an equity lens. As you can see here, the foundational areas are based in community-specific services, including communicable disease control, chronic disease and injury prevention, environmental public health, maternal, child, and family health, and access to and linkage with clinical care. The foundational capabilities include assessment and surveillance, community partnership and development, equity, organizational competencies, policy development and support, accountability and performance management, emergency preparedness and response, and communications. The 10 essential public health services have served as the premier framework for public health practice for the past 25 years. This framework was revised about 4 years ago to update it to reflect current and future public health practice. The accreditation process requires the health department to systematically describe how their programs, activities, and performance address each of the 10 essential public health services. While there's overlap with the foundational public health services, specifically in its emphasis on equity, the 10 essential public health services provide a more detailed framework to the promotion of policies, systems, and services that enable health and well-being. The 3 arms of the 10 essential services are assessment, policy development, and assurance, and are detailed here. To assess and monitor population health, to investigate, diagnose, and address health hazards and root causes, to communicate effectively, to inform and educate, to strengthen, support, and mobilize communities and partnerships, to create, champion, and implement policies, plans, and laws, to utilize legal and regulatory actions, to enable equitable access, to build a diverse and skilled workforce, to improve and innovate through evaluation, research, and quality and improvement, and to build and maintain a strong organizational infrastructure for public health. So I would be remiss if I didn't emphasize the comprehensiveness of this process and the undertaking that it is. While hospitals, schools, and even fire departments have had an established accreditation process for many years, the concept of public health accreditation is relatively new. This timeline shows an abbreviated history of the milestones that led to the establishment of a national public health accreditation process, as well as MDH's participation in that process. The history started in 2003, when the Institute of Medicine called for a national steering committee to examine the benefits of accrediting governmental public health programs. Shortly after, the CDC announced support by naming accreditation as a strategy to strengthen public health infrastructure in the Futures Initiative. In 2005, the Exploring Accreditation Project was launched. Its objective was to develop recommendations regarding the feasibility and desirability to implement a national public health accreditation program. And shortly after, just in 2007, FAB was created. Once FAB was established, it took a few years to define and promote what public health accreditation would look like. Health Department accreditation was launched in 2011, and MDH achieved accreditation for the first time in 2017. As of today, there are 42 state, 397 local, and 6 tribal health departments accredited through FAB. Typically, accreditation is granted in 5-year intervals. However, due to the pandemic, an extension was granted, and therefore MDH submitted for reaccreditation this past January. We are now in the process of operationalizing our plans and preparing for our FAB site visit this fall, which is the final step in our reaccreditation determination. The Strengthening U.S. Public Health Infrastructure, Workforce, and Data Systems Grant is a 5-year CDC grant to strengthen U.S. public health infrastructure, workforce, and data systems. I mention it here because this funding has been integral to multiple initiatives associated with our accreditation efforts, including funding for workforce and contracts for accreditation initiatives. A tremendous amount of planning has been executed to develop our accreditation application. The strategic plan was an integral piece to our accreditation package, but certainly not formulated in isolation. It is a component of the process developed alongside a state health assessment and a state health improvement plan, or a SHAW and a SHIP. The SHAW is a systematic approach to examining statewide data to identify public health needs. The SHIP is a long-term system-wide plan to address those public health needs identified in the SHAW. Integral to the development of the SHAW and the SHIP was the administration of a community input assessment and a public health systems assessment, both to further inform our understanding of our current health landscape, as well as address and acknowledge concerns and capabilities within Maryland. Other significant components to our reaccreditation submission included a quality improvement plan, which involve the development of a performance management system, as well as a workforce development and a communications plan. This slide depicts how the elements of a reaccreditation are aligned. The SHA informs the SHIP, and the results of the SHA and SHIP in turn set the stage for an agency-specific strategic plan that details the state health department's role in addressing state needs. This, however, describes an ideal scenario. In reality, our process looked a little bit different, our strategic plan being formulated adjacent to our SHA and even preceding our SHIP. The Maryland Department of Health titled their Health Improvement Initiative, Building a Healthier Maryland. This collaborative initiative convened dozens of organizations and partners across Maryland, including local health officers, local health improvement coalitions, sister state agencies, and partner organizations to revisit and set new health priorities and actions. A steering committee was identified to lead the effort with representatives from diverse organizations across the state. Our SHA analyzed data across more than 60 metrics, reviewing length of life, quality of life, social and economic factors, clinical care, health behaviors, and the physical makeup or environment to describe the makeup and the health of Maryland. Metrics ranged from mortality to seatbelt use and were compared to both national rates and goals. The recent top 10 leading causes of death in Maryland represented here is one example of some of the critical data that influenced our analysis. Critical to the output of the SHA was also its ability to highlight disparities and priority populations where health equity could be improved. For example, this graphic demonstrates the increased proportion of chronic conditions such as depression, diabetes, heart disease, obesity, and smoking among individuals living with a disability. Community input was an integral component to the SHA. Last fall, MDH launched a community input survey in 5 languages to solicit feedback from Maryland residents concerning what they perceived as the most pressing health issues in Maryland. Invitation was posted on our social media, promoted in a press release, and shared broadly with partners. This slide depicts an example of the types of information that were collected, with residents identifying mental health, access to healthcare, homelessness and affordable housing, chronic diseases, and gun violence among the most important health issues affecting the health and well-being of their communities. The survey received over 4,500 responses, and while responses were concentrated in Central Maryland, all regions of Maryland were represented in some capacity. Beyond just the numbers, this survey allowed for qualitative responses, providing some very impactful words to the experiences and humanity behind the concerns. The results of our SHA led directly into the development of our State Health Improvement Plan. The SHIP is a 5-year plan, or the typical life of an accreditation cycle, that responds to the results of the SHA and describes how the state health department, the public health system, and the communities it serves will work together to improve the health of the population. The steering committee for the SHIP comprised 42 members representing local health departments, local health improvement coalitions, MDH, and other state agencies, as well as nonprofits and other community organizations. Members met 9 times over multiple months to collaboratively develop priorities, goals, objectives, and metrics. The current plan identifies 5 priorities. Take note of the 3 priorities indicated with blue stars: chronic disease, women's health, and violence. As we will later see, these themes recur and align with priorities represented in the strategic plan. Critical to the development of a SHIP is an awareness of what organizations and services are already being offered, what populations are being served, and to what capacity. The Public Health Systems Assessment was administered with just that intent, to identify how effectively the 10 essential public health services were being practiced and delivered across the state, allowing for the identification of any gaps. This survey-based assessment gathered information about organizations, the services they provided, the populations they served, the health concerns they addressed, and what active community building activities were occurring across the public health system of Maryland. The steering committee identified key organizations across the state for inclusion in this process. Additionally, they were invited to extend the invitation to any additional partner organizations. 110 organizations responded, including nonprofits, local health departments, colleges and universities, and other state agencies and medical clinics. As depicted here, public health, healthcare access and utilization, family well-being, education, mental or behavioral health, health equity, and chronic diseases were reported as areas of work in more than half of all respondents. Multiple questions, such as those highlighted here, solicited information on services provided to specific populations, such as individuals living with disabilities or LGBTQIA populations. This allowed for an understanding of the extent of services offered to specific populations system-wide. While this was just a brief overview of the Building a Healthier Maryland process, this type of planning and evaluation set the stage for the development of a strategic plan. Unless you have participated in previous strategic planning processes, you may be wondering how one approaches this. The Association of State and Territorial Health Officials, or ASTO, offers a strategic planning learning lab, which brings together public health leaders across the country to share ideas and learn best practices from one another. Over 50 members across the U.S. and its territories participated in this learning community, which discussed how to develop and implement a public health strategic plan. I was fortunate to participate in this learning community, where I learned how to develop, refine, and launch our strategic plan through topics including internal engagement, health equity in strategic planning, underlying contradictions, action planning for successful implementation, and aligning with performance management. So what is a strategic plan? Tangibly, it's a document that outlines an organization's goals, objectives, and planned activities, but intangibly, it is much more than that. It is a process. This allows an organization to define what they see as the future vision and the actions needed to achieve and measure that vision. If you research strategic planning, you will find that the specific number of steps described vary, but ultimately all processes follow the same basic cycle of 1, preparing the plan through an assessment of the current state of the organization and setting the direction for where they want to head. 2, drafting the plan by setting goals and strategizing actions. And 3, implementing the plan with effective rollout, monitoring, accountability, and revisions as needed. PHS organized the Public Health Workforce and Infrastructure Office to lead this effort. Strategic planning centers around answering 3 main questions in organizations: why, what, and how. The why is described through the vision, mission, and values. This centers a framework for the what. The what refers to what the organization wants to achieve, specified in priorities or focus areas and goals. This requires identification of current assets and barriers, such as through a SWOT analysis. The how speaks to the actions needed to achieve the what, and this is described through objectives, activities, and performance measures. Part of our why was predetermined. MDH has an established vision and mission which guides their work. However, when I started, we did not have an identified set of values. I brainstormed the values I had seen displayed in the time I had been working with the department. I proposed them to my team and solicited feedback. Then we provided a list of proposed values to all of the PHS local health department health officers, directors, and employees who were engaged in supporting the MDH application for reaccreditation. We asked participants to select their top values and to provide justifications for why they felt that value represented the organization. Results were tabulated, and 7 values were very clearly named most frequently: collaboration and partnership, science and data-driven, equity, integrity, leadership, to serve as the environmental scan. I won't go through the details of our SWOT results, but I want to emphasize the utility of this exercise to provide participants with the opportunity to reflect and prioritize public health concerns as a stepping stone to the development of a list of the top 5 requiring a strategic response. These planning sessions were truly an organizational effort, requiring collaboration and input from partners across the organization. Once preparations were done, it was time to plan. PHS leadership analyzed the results of the summit, and 5 priorities were identified: public health infrastructure, including workforce, chronic disease prevention with an initial focus on diabetes, women's health, reducing overdose and the negative health outcomes associated with substance use, and violence prevention. Note our recurring themes marked by blue stars. Once priorities were identified, all planning participants were polled to validate these priorities. Work groups of about 10 to 20 individuals were then developed, comprising subject matter experts across PHS to provide valuable insight to ongoing and proposed programs and activities. A work group lead was identified for each work group. Over multiple sessions, each work group proposed goals and objectives for their respective priority area. To maintain focus, each priority was requested to develop 2 to 4 goals, each having 2 to 5 objectives. After we began writing our goals and objectives, it became clear we needed to address our how. Specifically, how would we meet our goals and measure and evaluate our performance? We recognized that writing an objective was easy. What became the challenge was making it SMARTY: specific, measurable, achievable, realistic, time-bound, inclusive, and equitable. We had to ask ourselves for each objective, does it address the following? Does it address what the program hopes to accomplish? Does it establish a benchmark? Does the program have capacity to achieve it? This came into play a lot. Wonderful ideas were proposed, but if the funding or the personnel were not available, we didn't have the capacity to achieve it. Did it reflect the population in consideration? Was there a deadline for completion? And were socially and economically marginalized individuals and groups represented? And lastly, was justice being promoted? Ultimately, we only know what we can measure. Oftentimes, we found ourselves trying to use a metric that is already being monitored. However, we would have to ask whether or not it actually measured the sentiment of the objective we were defining. Identifying a metric must take into consideration how it will be calculated, who will be responsible for calculating and reporting it, how often it should be measured, what the current baseline for the measurement is, and where do we hope to get. Lastly, evaluating for health equity often requires a metric to be disaggregated by some demographic, whether it be race, income, education, geography, age, or something else. Understanding the feasibility of the data collection and reporting of such raw data is so important, and it dictates how the objective is framed and how data would be collected. There are often multiple ways to measure impact. Selecting measures must include discussion of which measure best captures success. These are often labeled key performance indicators. These quality measures help inspire excellence by answering the question of how well are we doing, and have our initiatives produced change. They must consider the inputs and the outputs and differentiate between process and outcome measures. Process measures concentrate on the methods and activities in a project and speak about
Excuse me, Stephanie. We couldn't hear you.
just now. You can't hear me?
Now I can hear you, but we lost the audio about a few seconds, and it happened before too. And I can hear you now.
Okay. Sorry about that. Should I go back?
Just start with the beginning of this slide.
Okay. This process revealed an opportunity for quality improvement in our department through the development of a performance management system. No centralized system for collecting and monitoring performance data across the administration existed initially. We performed a root cause analysis using a fishbone diagram centered on improving the performance management system in order to plan necessary people, methods, materials, equipment, and environment to initiating and implementing a performance management system. We also utilized the Plan, Do, Study, Act, or PDSA model to plan our change. And then we began developing our system, initially through a simple Excel spreadsheet with the intention of progressing to a program known as Clear Impact. Performance management often feels like this juggler, many balls in the air that we have to track and keep moving to ensure we are successful in our ultimate goals. The performance management system strives to streamline that approach, allowing for monitoring of measures from all of the plans we've discussed today. More importantly, the data will be captured for review at even more macro levels, for MDH-wide and even at the Governor's Office of Performance Improvement. This group picture depicts the collaborative gathering of chief performance officers for all of Maryland's state agencies. I'd like to provide a special shout out to our chief performance officer and one of my supervisors, Dr. Catherine Feldman, noted by my arrow. This sharing of data across different levels within MDH and even to the governor's office brings me to another important topic, the intentionality of aligning the strategic plan with adjacent plans, both internal and external. Aligning plans allows you to engage the community in a shared vision, providing a platform for collaborative partnership and evidence-based decision-making. It increases communication of all players within our public health infrastructure and system, and it projects visibility. By networking partnerships, the public health system benefits in its inherent capacity for expansion, sustainability, and scale. It convenes a larger team to the table, which allows you to excel in your brainstorming efforts by streamlining objectives, activities, and performance measures. You increase efficiency and reduce redundancies, ultimately leading to more efficient utilization of resources. Just like this snail with a jetpack, this allows you to multiply impact and produce enhanced outcomes. In this case, we had multiple plans to consider as we were developing our strategic plan. These included internal plans such as those already mentioned, the SHIP, Workforce Development Plan, Quality Improvement Plan, and Communications Plan. However, MDH doesn't work in isolation. Given the complexity of state public health, the statewide integrated health improvement strategy, also known as SIHIS, the HEAD model, and the 2024 state plan, also known as the governor's plan, were plans external to MDH that needed to be considered as we developed our plan. I won't go into detail about these plans, but I want to emphasize that while the goals and objectives and activities of the SIHIS, AHEAD model, and the state plan all have their individual purposes, alignment of those goals, objectives, and activities within the strategic plan allows for collective action and increased capacity with limited redundancies. Before I move on to discussing implementation, I want to highlight the critical importance of bringing executive leadership along throughout the process. Engaging leadership ensures the planning efforts reflect broader leadership interests and priorities. This part of the process can sometimes be a bit of a balancing act, giving voice to both the participants engaged in the process and leadership, and it may lend itself the need for multiple revisions in order to best capture the whole voice. Yet once our planning was complete and the plan was approved by leadership, it was time to implement. There are multiple points to consider when approaching implementation. First, operationalizing a new plan requires change management and a lot of communication with regular team meetings to monitor progress and recognize success or setbacks. Included in these meetings should be an intentional plan to motivate participation in the performance management process, which must include an avenue for feedback on adjusting metrics as the plan's implementation evolves and responds to emerging issues. Assigning implementation responsibilities and emphasizing the plan as a part of the day-to-day work and not outside of it is critical. We launched our plan through a town hall, the use of a website, and multiple smaller meetings to present to entities both engaged and affected by the process. Now, I'd like to end with the lessons learned from these experiences. This practicum experience has taught me multiple significant aspects to a public health department's operations and journey towards accreditation. First, nothing in public health is done in a silo, and collaboration creates better outcomes. These processes are time intensive, requiring integration of countless elements of the whole system and multiple iterations of revisions in order to develop the most refined and accurate version of what is a SMARTY objective. This process involves engaging more partners, program representatives, and subject matter experts. And that brings me to a very important point. Seek out the subject matter experts. There are so many diverse niche areas to public health and so many programs running at any given time that nobody is an expert in all of them. Plans, performance, and evaluation must be designed together. Without a well thought out method of evaluation, it isn't a whole plan. And also, a plan just can't cover everything. The landscape of public health is so broad, ranging from access to food and healthcare to whether or not your neighbor has a fenced pool and the neighborhood has proper lighting. Priorities have to be made, and those priorities can change rapidly. And lastly, public health is dynamic. It is always evolving based on emerging issues, population changes, and the impact of leadership as it changes and those priorities that it comes with. Keep abreast to what is happening in legislation. It affects the expectations and resources for public health activities. Funding and workforce are so interrelated. Workforce sustainability requires funding. I'd lastly like to end by thanking the CDC PMRF, program faculty and staff, my co-resident and my supervisors, as well as team members at MDH. I'd like to send a special thanks to Dr. Catherine Feldman, who's a former PMRF alumni, and Dr. Jessica Sharia, who's a current CDC CFO. These are my references. And I'm now open for any questions.
If you have any questions about this presentation, you can put them in the chat. And while we're waiting for some questions, Stephanie, I'm just curious. It's such a large public health accreditation. It's such a long process, and it's also a difficult process. And I was wondering what you felt was the most challenging thing to have to address in all the various parts of it for the accreditation.
I think one of the more difficult pieces to address is that at some point you just have to make a decision, and it's not going to make everyone happy. So because there are so many different pieces to public health and you want to bring as many voices to the table, when you do that, there is a wide diversity of what people think is the most important. And at the end of the day, you cannot cover everything, as I mentioned at the end. And our team had to make decisions. I think that sometimes that was difficult because we knew certain topics were so important in so many ways, and how could we weave them into other aspects of the priorities we had already selected was a balancing act. So I think that became very difficult. We had so many invested people, and trying to both produce a product that spoke to everyone's concern, but also a product that was reasonable and manageable and able to be accomplished with our funding and resources was a large challenge.
If there's any questions, you can enter them in the Q&A box. Sorry, not the chat. I think I mentioned the chat before, but put it into the Q&A box for questions for this presentation. How many people would you say you had to work with in order to, I mean, you talk about reach out to these experts, we're not in a silo, but how many people did you have to particularly contact and talk to about this reaccreditation, would you say, in the year there?
Well, I'll make this more plan specific. So with the strategic plan, I want to say that there were probably between 60 and 80 people involved at some point, whether that was participation in a work group or participation in the initial planning for priorities, or the planning to create values. So there were different aspects of the plan that brought in different individuals. And honestly, I didn't actually ever tally up the number of people involved, but with every step of the process, more people got involved. And as I mentioned, we had 5 priorities, 5 work groups. Each work group had a minimum of 10 people. So there really was crossover between the different aspects of it, but a lot of people involved. As for the ship brought in people from all across the state. And that steering committee, while it had 32 members, the number of people that were later involved in some capacity multiplied greatly. So the actual number of individuals involved in this process is probably, I don't know, close to 200 or more. I'm not sure, but it was a lot.
You have a question about, was the Public Health Accreditation Board reaccreditation pursued under version 2022 standards and measures?
That's an excellent question. I didn't go into detail about that nuance, but there are 2 versions. And because MDH had already achieved accreditation at a certain timeline, we were actually working under the 1.5 version.
And how much say did the governor's office have on the strategic plan priorities?
I do not believe that the governor's office was involved in developing any of the priorities for our strategic plan, because the strategic plan was centric to public health services within MDH. However, once the governor's plan was public to us, we tried our best to align metrics within our SHIP and our strategic plan with what the governor was also trying to achieve.
And was there a survey for the all Department of Health members to look at the priorities for the strategic plan? Was there any type of survey done of all of the employees?
So the local health department health officers, so the individuals that run each health department within the state of Maryland, they were involved in that process of validating the priorities, helping develop them and then validate them.
And who pays for the health department accreditation, and how long does it last for?
That's an excellent question. So the accreditation cycle is for 5 years. So that is why the SHIP is planned for 5 years. The funding comes through multiple different sources. I did mention that one grant that is being utilized to help with some of the costs of hiring workforce and hiring contractors associated with accreditation efforts. And that's the Strengthening U.S. Public Health Infrastructure Workforce and Data Systems Grant. As far as other funding, I'm not actually entirely sure. I'm not sure if my colleague on the line would have any more information exactly about where that funding comes from.
And is this for county and city health departments as well? And if so, what would go into, how would it be different for a smaller health department? So could a smaller health department also get accredited?
Yes, that's a great question. So smaller health departments are also eligible to get accredited through FAB. Currently, there are 397 local health departments accredited through FAB. The process, I'm not sure how it may differ in some ways, but the main goal is still to demonstrate how those 10 essential public health services are delivered and practiced in the jurisdiction that health department is working in. I believe Ohio actually requires local health departments to be accredited, but that's unique. Most states do not require that of their local health departments.
And just a note for the chat, because you may not be able to see it. Jessica Achara, your supervisor, said that the state is responsible to pay for accreditation fees in the chat. The next question is, were there specific strategies utilized to educate various team members or departments on the reaccreditation process, especially with regards to potential workforce turnover that has occurred between the initial accreditation and then this reaccreditation process?
Yeah, that is an excellent question. So as I mentioned, when I started, I did not have a background in strategic planning. And the rest of my team was also kind of learning at the same time as we were doing this. So we found that use of ASTO was extremely helpful. I mentioned one of their online communities that I participated in. However, our team as a whole participated in multiple of those communities. And in terms of workforce turnover, luckily through the time frame that I started on the process, I would say that we completed this process in a much quicker speed than I would say most health departments do, because of the time pressures we were under at the time when the decision was made to pursue reaccreditation. And so we luckily didn't have turnover to any impactful degree on our team during that time frame, but that is a big concern, and actually one of the reasons why we're working so hard to implement the FIG grant where we can to bring workforce on and help with this process, so that it's not something that's done the year before it's due, but really it's supposed to be a process that's being worked on from the moment it's submitted to be operationalized, implemented, and then really be preparing for that next submission all throughout.
All right, we have time for one final question. And the final question is, how are the results used and the health department held accountable before the next reaccreditation cycle?
Excellent question. I haven't actually personally been a part of seeing how that happens. The prior strategic plan that was produced was set to end in 2019. And we know that what happened immediately right after that was a pandemic. So really, I came in at a time when things were already really changing in need of revision. But for going forward, our plan is to assign teams to different aspects of our performance management system and hold these regular meetings to hold individuals accountable, as well as be very transparent with our residents and our constituents that are trying to benefit from this plan and be a part of this plan. So by establishing a system where we can track measures and report out on them, as well as dashboards, which are built into multiple aspects of this plan, we do hope to hold accountability and transparency that way by making it public knowledge how certain things are progressing. And we did that by highlighting core measures or metrics that we will be reporting on publicly.
Great. Well, thank you, Stephanie, for the presentation and the question and answer. We're now going to transition to the next presentation. I have the pleasure to introduce Dr. Jane Gwira Baumblatt, who's going to be talking about the National Health and Nutrition Examination Survey. So she'll talk more about the initiative focused on assessing the health and nutritional status of both adults and children in the United States.
Thank you, Mike. Can you all hear me?
We can hear you. We just don't see your slides yet.
Okay. It says I'm sharing, so let me try that again. Okay.
Now we can see your slides.
Now, okay, perfect. All right. So good afternoon, everyone. I'm going to talk about diabetes and NHANES, as Mike said, and we're going to do a population look in adults. But before I start, I just wanted to say what a privilege it's been in the last 2 years to complete the CDC Preventive Medicine residency, and to do it under such an awesome leadership. So Mike, Lillian, Gabby, Laverne, thank you all so much for your support. Stephanie and I have really just grown in this. And we are closing out the program, so you know, it's really nice to have been a part of something great here. All right, so back to diabetes and NHANES. I have no disclosures. So this presentation will include background information on diabetes, and then a discussion of NHANES. I'll talk about mission, sample design, data collection, and then I'll present my analysis of NHANES 2017-18 diabetes data, and then some brief information on the upcoming NHANES 2025 survey, since we've been out of the field for a while. Okay. So many of you in this audience likely know much of this background information on diabetes already. So I'll just highlight the key points here. So diabetes mellitus is a chronic disease and a metabolic disorder resulting in elevated blood glucose levels, categorized into type 1 and type 2, which make up the vast majority of diabetes. But to be complete, we also add that there is a very tiny group of diabetes that are neither type 1 nor type 2. And then there's gestational diabetes, diabetes in a pregnant person who did not have diabetes prior to pregnancy. But that's not the focus of this talk. So just think type 1 and type 2. And of all the three, of the two types, type 1 and type 2 is the most common. And I'll show some statistics in a little bit. So the diagnosis of type 1 or type 2 diabetes can be made with any of the 4 testing methods below. So I won't belabor these except to say that for NHANES, we measure both the fasting plasma glucose and the hemoglobin A1C. And the A1C is a measure of glycosylated hemoglobin, which gives an estimate of the average level of blood glucose over the last 2 to 3 months. Okay. So diabetes is a major cause of morbidity and mortality in the US. Type 2 especially can remain undiagnosed and progress over time, and affects multiple organs in the system. So we have neuropathies, retinopathies, nephropathies, coronary artery disease, and can even lead to strokes. So this infographic from CDC targeting the general population is basic, but it's really helpful, I found. So let's go through it a little bit. Here we see that both type 1 and type 2 diabetes can develop at any age, but type 1 tends to skew younger, while type 2 tends to skew older. So about 18,000 youth are diagnosed with type 1 diabetes, and this is 2017, compared to 5,300 youth diagnosed with type 2. So we don't yet know how to prevent type 1, but the good news is that most cases of type 2 can often be prevented, typically with lifestyle interventions, sometimes with medication interventions in the prediabetes stage. So notice here what I was talking about, that the majority of cases of diagnosed diabetes are type 2, that's about 90 to 95%. So this is another report card put out by CDC for diabetes. This is 2021 data. So here we see that about 38 million people in the US have diabetes. That's about 10% of the population, or 1 in 10. Yet 1 in 5 don't know that they have diabetes. And this will become important later on when I talk about my analysis about those who don't know, or the undiagnosed. And then we won't be discussing prediabetes in this talk, but it is an important precursor to diabetes. So here we see that a staggering, 98 million, or close to 3 times more people have prediabetes than do diabetes, and yet 8 out of 10 of them don't know it. So this is another infographic, super helpful, just showing the risk factors for diabetes that are well known to many of you. So family history, physical inactivity, being overweight, and age greater than 45. And the medical costs to society are staggering, in the billions, actually. So specifically for 2021 estimates, 413 billion. We also know that people with diabetes are at higher risk of serious health complications, making medical costs for people with diabetes more than twice as high as for people without diabetes. And the medical costs, I think, is a great argument for investing in public health efforts that target prevention of diabetes. But this is the audience that already knows that about prevention. So I will move on. Okay, so just as concerning as the 38 million people currently living with diabetes is the trends over time. This is using NHANES data, and it's comes from the National Diabetes Statistics Report put out by CDC. And these data are from 2001 through March of 2020. So here we show age-adjusted percent estimates of diagnosed, undiagnosed, and total diabetes. Total and diagnosed, the 2 top lines, have been steadily increasing from 2001 through 2020. So that's alarming. The undiagnosed diabetes is essentially staying flat, so around 3%, which just means that we're doing a better job diagnosing diabetes, but it's still alarming that the trend continues to go up. So here is, I love these maps. The map shows in picture format what the trends graphs just showed in the last slide. So essentially you see the map getting darker. And these are from the National Diabetes Statistics Report. But unlike the trends graph shown earlier, these are only diagnosed diabetes. And these data come from CDC's Behavioral Risk Factor Surveillance System. And these are also age-adjusted county-level prevalence of diagnosed diabetes. And this is US adults only, 20 years of age and older. And this is 2004 through 2021. So these prevalence estimates come from multiple data sources, including CDC's National Health and Nutrition Examination Survey, which is the focus of this talk. But other sources, important sources, also include CDC's Behavioral Risk Factor Surveillance System. That's what you saw with the maps. And then the National Health and Interview Survey also has diabetes data. And then the National Vital Statistics System for gestational diabetes data. And then we also have non-CDC sources, such as the Indian Health Services National Data Warehouse. And the U.S. Diabetes Surveillance System, or USDSS, is CDC's warehouse for all things diabetes. It's a really useful resource if you're looking for diabetes surveillance in general, really comprehensive. Okay, let's delve into NHANES. So the mission of NHANES is to assess the health and nutritional status of adults and children in the United States. NHANES is the only nationally representative survey with physical measurements. So it produces population-based prevalence estimates of numerous health conditions and risk factors like diabetes, but it also has estimates of awareness, treatment, and control of different diseases, prescription medication, dietary supplement use, nutrition status, dietary choices, and environmental exposures. So quite comprehensive. So the Division of Health and Nutrition Examination Surveys, or DHANES, where I've been fortunate to spend the last year, operates NHANES. And it's mostly a federal staff of about 62 as of this April, so small but mighty, with expertise in multiple areas. So we have statisticians, epidemiologists, environmental health folks, clinicals, lab, and they're all responsible for the planning, operations, informatics, and the analyses. And then there's a contracted field staff consisting of multiple traveling teams that operate 48 out of 52 weeks of the year, and they're responsible for data collection across the country, in addition to supporting the staff in operations, survey planning, and survey design. So about a third of funding for NHANES is from our collaborators, and it's a total cost about $40 million per year. And here they are, our multiple collaborators, 30 federal partners providing various levels of technical support, survey planning, content, data quality, and of course, very important, financial support. Okay, so now we're gonna delve into the nuts and bolts of how our data are collected. So we use a complex multi-stage probability sampling design to select the NHANES participants. So going from stage 1, PSUs here just stands for primary sampling unit. Those are the counties. And then stage 2, the segments within the counties, stage 3, the households, and then stage 4 down to the participants. NHANES is designed to be representative of the civilian, non-institutionalized resident population. So some groups are not eligible. So for example, all persons in supervised care or custody are not eligible, or in institutional settings are not eligible, active duty military, and then US citizens residing outside of the 50 states and DC. In addition, oversampling is done to increase the number of individuals in the sample in particular subgroups of interest, and therefore increase the reliability and the precision of the estimates of these population subgroups. So a bit of NHANES history here to help you kind of put it together of how we got here. So after the passage of the National Health Survey Act of 1956, the National Health Examination Surveys, or NHES, were conducted in the 1960s. And then the nutrition component was added in 1971 to the first cycle of NHANES studies. And then NHANES was conducted in a series of periodic surveys over time until 1999, when continuous data collection on the current NHANES began. So that's where we are now, continuous data collection, unless you have a pandemic, and I'll talk about that later. So this table lists all the surveys that have been conducted along with the most current data collection, August 2021 to August 2023. And over time, the length of data collection and age groups have changed. Starting in 1999 with continuous NHANES, all ages are eligible for selection and data have been released every 2 years. Survey content also changes somewhat between 2-year cycles, but not much. In March of 2020, with the pandemic and the interrupted data collection, that interrupted our release schedule. More to come on that again. And then finally, every 2 years, every 2-year cycle includes about 10,000 participants. Right, let's talk a little bit about the actual data collection. So NHANES is conducted through an in-home questionnaire, most recently done by phone. And then examinations and lab testing are completed at mobile examination centers, or MECs. And then in addition, there's a telephone follow-up and other follow-up studies depending on the survey cycle. The in-home questionnaires are conducted by a team of interviewers. They travel to each primary sample unit, or PSUs, in the counties, and then the in-home questionnaire collects demographic data, health conditions, health insurance, healthcare use, prescription medication, dietary supplement use. In the prescription medication component, participants are asked to show their bottles of medication so that we actually know we're getting correct information, and that's logged in by the interviewer. And then for the in-home interview data, those are collected electronically, and they're standardized to ensure consistency over time and between participants as well. And the in-home interviews are recorded and reviewed for quality assurance. So the mobile examination centers operate across the country, actually, to gather health examination data in a controlled environment. And I will show you some newer models that we have coming up. So the MEC standardizes data collection in several ways. There's one team per MEC trained to conduct examinations in a systematic manner. Specimen collection and exam protocols are all standardized, and equipment are regularly calibrated. So the lab tests that are in NHANES include, but not limited to, nutrition biomarkers like levels of vitamins, minerals, bioactives. And then we have chronic disease markers, lipids, like markers of diabetes, markers of inflammation, endocrine function. Undiagnosed diabetes estimates come from our measures of fasting plasma glucose or hemoglobin A1C levels. And this is among people who don't report having a diagnosis of diabetes. And then immunization status, infectious disease status, those are also assessed. Hepatitis, certain STIs, toxo, H. pylori. And then we have lab assays to measure environmental exposures. We can do some pesticides, herbicides, hazardous household chemicals, heavy metals, and even secondhand smoke. And then the telephone follow-up happens for different topics: diet, consumer behavior, infectious disease, follow-up interviews, and then other special topics. So how are we doing for participation rates? So this graph shows trends and response rates for 10 NHANES surveys, starting from 1999 through 2018. The orange line up top represents those who have been screened, so 93.1%. The brown line right on top of the blue line, or gray, depends on how it looks on your screen, trending above the blue line, that's those that are interviewed, and then the blue line are those that have been examined. So 50.7% is actually pretty good for a survey, considering that so many surveys are in the 20s and 30s. So we left the field in August 2023 after completing a 10-year contract cycle with Westat. And the plan is to return to the field in January of 2025 with a new contractor, RTI, with new measurements for visual acuity, spirometry, and retinal imaging. Retinal imaging is exciting because we can also see diabetic retinopathy and hypertensive retinopathy and these other diseases that the eye could harbor for people who don't know they have these other chronic diseases. And then NHANES will remain a population-based survey, and there will be in-home interviews and then in-person exams in the mix. So if you recall, I mentioned the pre-pandemic data earlier. So let me just talk a little bit about that right now. The survey was halted in March of 2020 due to the pandemic, and we were able to go back into the field in August of 2021 to complete another 2-year cycle. So that is the latest cycle that we have. And these data, very exciting, will be released later this year. But we also have a pre-pandemic data file that's from 2017 through March of 2020, which is unusual in that it represents a 3.2-year sample rather than the typical 2-year samples. So this is an interesting data file because sample sizes are larger, and so we expect that standard errors will generally be smaller than for the 2-year data sets. I used the last 2-year cycle that we had pre-pandemic for my diabetes analysis, and I'll talk a little bit more about why I did that. Okay, so now that we have a sense of how we got the data, I'm going to move on to the analysis, and I'll use my analysis as the example. So for those of you data geeks who are interested in the analysis process, the data are publicly available on the NHANES website. And so for access to NHANES data for analyses, you start on the NCHS homepage and click the National Health and Nutrition Examination Survey. And I typically use this survey data and documentation tab for access to all data for all survey years. And that will look like this when you click on that. So for example, for my analysis, I used 2017-2018 survey cycle. And then clicking on this link takes you to the data files, which can be easily downloaded. And here's where they live. And each data cycle has a page just like this one showing the types of data files that are there, demographics, dietary data, exam, et cetera, along with details on the content and information about using the data. All right, so now that we have our data, once they're downloaded, you can manipulate it in SAS or any other programs, analysis programs. I used SAS Colorable Sudan to analyze 2017-2018 diabetes data. So I'm going to switch gears and discuss the data analysis. So one of the mainstay NCHS publications using NHANES data are the NCHS data briefs. These contain analyses on topics of public health importance by NCHS staff that uses NHANES data. There's online and PDF versions of these data briefs that are available with the citations are all in there as well. And this one is the last data brief on diabetes that we have published, 2013 to 2016. So that's 2 survey cycles. So because the last diabetes publication was 2013 to 2016, I decided to analyze 2017, 2018 before, rather than the pre-pandemic file. Typically, you want data from 2 cycles, but because the pandemic file disrupted the data collection, I actually wanted to know what the analyses would look like if we just had 1 cycle. So you've now learned about the NHANES data, which, as a reminder, it's cross-sectional, it's complex, it's multi-stage probability sample of the non-institutionalized population. So a little background on the 2017-2018 data. During 2017-2018, Hispanic, non-Hispanic Black, that's the NH there, non-Hispanic Asian persons, among other groups, were oversampled to obtain reliable estimates on these subgroups. So the race and Hispanic origin specific estimates reflect individuals reporting only one race, and those reporting more than one race are included in the total, but they're not reported separately. So the criteria, we used criteria from the ADA, the American Diabetes Association, to define diabetes, and participants were classified as having diagnosed diabetes if they answered yes to the question. Other than during pregnancy, have you ever been told by a doctor or healthcare professional that you have diabetes or sugar diabetes? So participants were classified as having undiagnosed diabetes if they did not report a diagnosis of diabetes by a healthcare provider, and their 8 to 24-hour fasting plasma glucose was greater than or equal to 126 mg per dl, or hemoglobin A1C was greater than or equal to 6.5%. And then total diabetes is the combined overall prevalence of diagnosed and undiagnosed diabetes and does not distinguish between type 1 and type 2. For my analyses, all estimates for adults age 20 and over were age adjusted by the direct method to the projected 2000 US Census population. And I used the age groups 20 to 39, 40 to 59, and 60 and over. And you'll see that in my graphs. So this pie chart shows the age-adjusted prevalence of diagnosed and undiagnosed diabetes among adults 20 years of age and older in the US. This is 2017, 2018. Diagnosed diabetes is the larger green slice, and undiagnosed diabetes is the smaller orange slice. And the take-home point here is just that during 2017, 2018, 14.5% of US adults had diabetes, and a quarter of them were undiagnosed. This graph shows age-adjusted prevalence, again, of diagnosed, undiagnosed, and total diabetes. And this is, again, US adults 20 years of age and older, and this is by sex. So in this graph, and actually in all my following graphs, the green bars are going to be diagnosed diabetes. The orange is going to be undiagnosed diabetes, and the number on the top in black is the total prevalence. So that's diagnosed and undiagnosed diabetes combined. And in this graph, there were no statistically significant differences in either total, diagnosed, or undiagnosed diabetes by sex. So here is the age-adjusted prevalence of diagnosed, undiagnosed, and total diabetes among US adults 20 years of age and older. This is by age group now. Here, my take-home is that the prevalence of total, diagnosed, and undiagnosed all increased with age, and this is actually a statistically significant linear trend by age. And also notice here that almost a third of adults age 60 and older, that's the last bar there, have diabetes. So 30%. So this graph shows age-adjusted prevalence, again, diagnosed, undiagnosed, and total diabetes in adults. And this is by race now. And total diabetes here was higher among non-Hispanic Black, non-Hispanic Asian, and Hispanic adults compared with non-Hispanic white adults. And here, my superscript there, that number 1, just means statistically significant differences from non-Hispanic white adults. And this graph shows age-adjusted prevalence of diagnosed, undiagnosed, and total diabetes among US adults, and this time by body mass index or BMI. And here we see that the prevalence of total diagnosed and undiagnosed diabetes all increase with increasing weight status category. And this is also a statistically significant linear trend. Notice here that the increase in the prevalence of total and diagnosed diabetes, so we're looking at the green bars and the total number in black above each bar. If you look at from normal/underweight to obesity was almost 4-fold. And the BMI categories, I just used the clinical categories. So less than 25, underweight or normal, 25 to 30, overweight, and greater than 30, obese. So in summary, we found a persistent message for diabetes data over the years that, again, in 2017, 2018, about a quarter of adults with diabetes don't know they have it. And so given the importance of prevention in diabetes and its outcomes, monitoring the prevalence of diagnosed and undiagnosed diabetes is actually essential to ongoing public health interventions. And I think this is actually the beauty of NHANES, and they're not paying me to say this, but I've actually found that this is a really cool thing because it's the only survey that we have that's able to measure undiagnosed diabetes. And then that gives us the population level data on the prevalence of total diabetes, which you don't get if you only measure diagnosed diabetes among US adults. So, and these data, once you get total diabetes, you can actually calculate disease burden, right, with crude estimates and population counts. It's very powerful. And I will end with two pieces of really good and exciting news. So as I mentioned earlier, NHANES 2021 data are being released this year, so stay tuned. And we are very excited in the division about the upcoming NHANES 2025 return to the field. And these are the new trucks that we were talking about. So it's all very exciting. And the logo, the top left logo is the one that won the logo competition for the trucks. All right, and I will end by thanking my amazing team at DHANES. Cynthia Ogden and Tony Nguyen were my supervisors par excellence. Cheryl Fryer helped me with analyses, and David Bryan helped me as well with the presentation, and Alan Simon is our division director, who is very amazing to work with. So thank you, and I will take questions.
Great, thanks, Jane. Wonderful presentation. This presentation is now open for questions. If you have any questions, you can put it into the Q&A box. I guess I'll start. With the NHANES, we've talked about before, sort of how the response rate, while it's good, it's going down. So I guess it's a two-part question. First of all, what is being done to try to make sure that the rates don't go down further, or to make sure that as many people as possible participate? And then second of all, how is the demographics different of the people who participate versus not participate? So the generalizability of this population.
All right, Mike, you're gonna make me say it. If you see one of these trucks, sign up. That's how we're gonna get people to go. So I think as with all surveys, it's gonna be marketing, getting out there, putting out, saying our presence is here, social media, telling people about it. Unfortunately, this is a trend that we see everywhere, not just in NHANES, where people are like, I don't want to give the government my data. It's like, oh, okay, but we're like actually the safest place to keep your data with like multiple levels of safety. So, so that is one thing. It is concerning. It always comes up, and it's a problem. So I won't say it's not, in terms of people being hesitant to give their data. And then the second part was, Mike?
The generalizability, sort of the how are the people who participate versus the people who don't participate. So really looking at it compared to the actual general population, how is the people who participate different?
So I think because of the survey design and the data being weighted to the general population, we are able to do we are able to say that our analyses are generalizable because of the weighting. It is true that if the response rate gets to be really low, and I don't know what that number would be, where you could say it's no longer generalizable, but that's why the data go through all these complex processes in terms of our amazing statistics group that does the weighting. And so it is generalizable at this point.
So questions are starting to come in. First question coming into the chat, through the Q&A, sorry, was what was the reasoning behind not including individuals in institutions in the NHANES data sets?
So the answer is that I don't know, as in nobody has told me. But if you look at like the process of collecting the data and how we do it, it would be really difficult practically to get one of these trucks to a federal or a state prison area and have people just be coming in and on these trucks. And so I think logistically, I don't know how that would work. I don't know if there's anybody on here who knows the history of that, but I'm just thinking practically, I don't know how we'd get people on and off the MEX.
Okay, next, and that makes sense to me, what you said. Next question's great presentation. A quick question about defining undiagnosed diabetes. As NHANES is a survey data, responders may report not having diabetes, but just one-time hyperglucose, for example. So lab tests would be a great proxy to confirm if the responders reported their diabetes diagnoses accurately. Could we say that it is not the undiagnosed diabetes, but the awareness of having diabetes? What could be the next steps to dive into this relationship, comparing the results from claims data? Thank you.
Claims data. Yes, so if anyone answers that yes, somebody has told them they have diabetes, a clinician, healthcare provider, doctor, then we still measure their fasting glucose and hemoglobin A1C, but we don't include that in the undiagnosed category, right? Because they are diagnosed. We only say undiagnosed if they answered no. So we're assuming that they are correct and that they've never heard anybody tell them that they have undiagnosed diabetes. And it's only that subset of people who their measurements for fasting glucose and hemoglobin A1C then puts them into diagnosed diabetes. So really, we are picking up a different subset of people. Claims data, I'm not an expert on claims data, but I think it's the same thing. Claims, you have to have a diagnosis. And so you would be looking at diagnosed diabetes, and it wouldn't just be people saying they had it, at least for claims. It would be by lab tests.
Next question, does NHANES return the results of the tests done to participants?
Participants do have access to their information. There is a handy dandy portal, just like when you go to your doctor and there's an EHR, where you're able to see it. And so I'm not an operations branch, I was in analysis, but my understanding is that participants have a way to reach the NHANES staff when they have questions. They're on call and people can reach back, and they have access electronically.
And next question is, what are the ways to increase screening for undiagnosed diabetes?
To increase screening. Okay, so these would be people who don't know they have diabetes. Mm-hmm. Since really NHANES is the only way that we have, only survey that we have that does this, the only thing I can think of, and we do this typically sometimes at the county level or at the state level, where people will go out and do a health fair, and people will get a stick, and then they'll say, this was your level, please follow up with your doctor, you may have diabetes. But typically, even with those, we tell people when we do health fairs to follow up with their doctor so that the diagnosis can be really verified. But that's one way that we do screening, aside from NHANES. Now I'm just talking about like my personal experience as a PHS officer. When we go out in health fairs, we tell people, you might have diabetes, your blood sugar was high, please follow up with your doctor.
And we just got a note of thanks to both you and to Stephanie from the prior residency program director, Tony Neary. Congratulations on all your hard work and upcoming graduation. I'm glad to see your progress, and I'm privileged to have been able to work with you for a while. I can't stay for the entirety of the lecture, but wish you both the best of luck and look forward to hearing about and watching your progress in the upcoming years.
Awesome. Thank you, Tony. Thanks for letting us in the program.
Thank you, Tony.
Yes. So that's all the questions that we have in the chat. I want to thank our presenters. Thank you, Jane. Thank you, Stephanie, for your presentations, for all the hard work you've done over the residency program for the past year. This is the final preventive medicine grand rounds, and Jane and Stephanie are the final two residents in the program before it closes. And it's been my honor to be able to be a part of your experience in the residency program. So I thank all the people who've attended this presentation, and we're signing off now. So thank you everyone for attending today. Bye.
Thank you.